Ready to go?
Senator,
I'm waiting for it to load.
Okay, we'll wait for a second. Thank you for your patience. We can blame it on the weather, right? Ready to go?
I'm waiting for it to load.
Okay, we'll wait for a second.
I think we're live, Senator. Go ahead.
Okay, thank you so much. Good morning, everyone. Good morning, everyone. I'm Senator Saud Anwar. We are going to start our public hearing for February 23rd, 2026. I hope everybody's staying warm and well and safe and indoors. I'll just kick off to my esteemed co-chair and then followed by our ranking member. I see Representative Gladys Teacher is here. So Representative McCarthy, you're up next.
thank you, Senator Anwar, and thank everyone for logging in today as you juggle snow removal, and stay safe and healthy out there as you remove the snow from all the locations. So with that, Senator Anwar, I'll turn it back over to you. Thank you.
Thank you, Madam Co-Chair. Representative Gladys Teacher.
Good morning, everybody. Hopefully everybody's warm and has heat on wherever they are, and effective Wi-Fi. Thank you.
Perfect. And I know there's another meeting happening for Appropriations Committee, so we'll probably see Senator Summers in and out between the two meetings.
And education, I believe.
Yes. So the work never stops. With that, we'll have our first speaker, which is Representative Andre Baker. Welcome. Representative Baker, you're on.
Good morning, Senator Anwar, Representative McCarthy Baker, and ranking members, Senator Summers. Thank everybody for relating this weather. I'm here in support of House Bill 5241. It's an act establishing a triple bottom line justice, known as TBLC, which is a demonstration pilot for Mount Growmore Hydroponic Farm Campus and Learning Center. One of the purposes of this bill is to tackle and complex climate issues, and how we can turn simply brownfields into health fields. This pilot will demonstrate that. Mount Growmore is an environmental hazardous landfill property that the community has come together and try to figure out how we can utilize this property for health wellness program. One of the initiatives that we have found is we have collected data over the years and figured out what we can utilize this program to address these issues. One of the frameworks that we come up with is a ICA 10V, which is a code that is used by the doctors to address asthmatic patients among children in the community. I use this as a framework to help look at health issues in the community and to be able to demonstrate how we can turn these brownfields, collect data for health and wellness, and be able to turn these properties into economical areas that will help the community in many ways and address disease control issues. We're going to collaborate with health professionals in the area to be able to help and address and identify how we can be able to use this. So one of the things we also are able to do is to be able to look at other community rural areas that are in Connecticut, not just inner cities, where there are many rural areas that have environmental problems, so that we'll be able to benefit from this actual pilot that we're going to do in the city of Bridgeport. We have many people that are on board with this. I had the opportunity to be able to work with the Yale, New Haven health students in the public field. And this is the next generation of actual looking into it and seeing how they want to address brownfield and utilize programs to be innovated in the future of the state of Connecticut, and then also outside of the state of Connecticut. So I know there are some people that are much more well-versed and that will be able to give more information on this particular pilot program. So I'm going to stop here and open it up for questions from committee members if you do have any.
Thank you so much, Representative Baker. I think what you're alluding to is something that is very clear, that health is a byproduct of a lot of things in our environment. Depending on what we are inhaling, what we are breathing, what water we are drinking, and all of those things just come together in our economic capacity. So this is why some of the communities are set up for challenges in the healthcare, and that's why we have such a major challenge of health outcomes being so different within a matter of 5 to 10 minute drive. We are probably one of the very few states in the country where a 10-minute drive can just change complete longevity of communities. So, and then you're alluding to tackling this and proving this point that most of us already know, but we need to prove it so that we can expand it and undo the wrongs that have been done for so many years. So I wanted to thank you for being a champion for this important concept, and then raising the awareness collectively that we as a state can do better. If one of my co-chairs or anybody wants to make a comment or ask a question, Representative McCarthy-Vahey, you're on.
Thank you, Senator Anwar, and Representative Baker. Thank you to you and all the people who've been working together with you on this initiative. And as you said, there are a number of, or a few other people who will be testifying a little bit later today. And I am happy to ask them questions or ask you, but just wanted to get a sense of what the work, from your experience, what the work has been to date, and how you're hoping this bill would help to change or transform that work.
So when you look at many brownfields that are all over the state of Connecticut and stuff, a lot of them are in neighborhoods where the it's a poor economical impact. And one of the things that you're looking at is to be able to, how do you tackle these particular properties? What can they possibilities from an economical standpoint, turn these properties around, clean them up and stuff, bring jobs, bring development in terms of housing or what they are. I mean, just an example, if you look at some of the brownfields and what things that have been done over the years, some of the brownfields, for instance, you know, you could look at Goodwin College, which is up in East Haven. That was part of that property was a brownfield, but that's been turned into a community of educational and on the waterfront, be able to clean up waterfront property and stuff. You have in Shelton, you have a farmer's market that was part of it was built on the brownfield. So that's bringing economic impact, but also bringing healthy as we turn brownfields into health fields and stuff. And at the same time, try to be able to identify what there are health issues that are in the area and stuff, working with the health fair to say, hey, if we have a strong amount of health issues that are contributing from the brownfield, and identify how we can minimize those in that area in terms of to cut down on the health services that are needed. If you have kids that are a lot of asthma, if you identify and minimize that, that's a cost saving from the health field. So that's some of the things that we want to be able to address with some of these now. But this is just examples of identifying health issues and stuff to minimize the cost and the impact that the state will have to pay out to address these health issues.
You're done, Representative McCarthy? Good. Okay. Thank you.
I just wanted to say thank you. Sorry, I didn't realize I was still muted, out of practice here. But thank you for that, Representative Baker. Thank you, Senator.
Representative Baker, this is very important conversation that you have initiated with you and other individuals who are champions of this important issue. I think we should have more conversations too after the public hearing and then see what can be done. I'm sure we'll, as a committee, look at the next steps. I appreciate your advocacy on this and your testimony.
Well, thank you for allowing me to speak. Thank you for even giving the opportunity for us to look at this bill and to be able to elaborate on, because it's an important issue, health, as you know, and that's what we're here about: turning health, environmental, changing the structure of environmental, and bringing economics to our areas where we have these brownfields and stuff, and help to redevelopment. So thank you once again.
Thank you.
And I look forward for us to dialogue with some more.
Perfect.
And how we can make this pilot program work and the state can benefit from it.
Thank you, Representative Baker. With that, we'll move to the second person on our list, which is Commissioner Jordan Sheff, along with the DDS team members. Commissioner, you're on. Thank you for being with us this morning.
And thank you, Senator Anwar. Thank you, Representative McCarthy Behe and Representative Claritas Dietra. I'm not sure that Senator Summers is with you, and to the rest of the members of the Public Health Committee. My name is Jordan Sheff. I am the Commissioner of the Department of Developmental Services, and I'm here to testify today on behalf of two bills. I have submitted my written testimony and won't read it to you, but I will one at a time summarize the two bills before you today on behalf of DDS. House Bill 5239, an act concerning the Department of Developmental Services recommendations regarding the Independent Mortality Review Board and Fatality Review Board. This bill makes technical revisions to the statute by removing outdated references to a 2014 executive order by Governor Malloy and incorporating those provisions into the statute. It removes duplicative requirements for the department to have a separate fatality review board and a separate mortality review board. Provides clear statutory responsibility for the department's mortality review board. And lastly, the language allows me, the commissioner, to consider addition of more board members on either a permanent or temporary basis to appropriately fit each review situation. That's my summary on House Bill 5239. Senator Anwar, I can move on to House Bill 5240 and summarize that next.
Please.
Yes, sir. House Bill 5240, an act concerning the Department of Developmental Services recommendations for various revisions to our statutes. Section 1 of this bill makes a technical revision to allow DDS to provide rent subsidy payments directly to a landlord. Sections 2, 3, 4, 5, and 6 revises the statutes regarding types of loans administered by the department for housing purposes to reflect current construction and material costs that will allow providers to access sufficient financing to cover their costs. The changes include modernizing outdated loan caps, aligning terms with current economic conditions. Providers will be able to access the DDS revolving loan funds to develop or improve residential options for the individuals we serve. That concludes what I have for notes on the two bills. I am accompanied by staff today, but I'm happy to take any questions. And if I can't answer them, I will ask staff to help.
Sure. Thank you, Commissioner, for your testimony. Could you elaborate a little bit about this loan program and how would there be transparency around it?
The revolving loan program has been in existence for decades. The bill doesn't change any of the current practices around that, just brings into line funding caps and some processes that are out of date, given how long it has been involved. We have internally an ethics review committee that, as well as teams both at DSS and DDS that review any applications for the revolving loan fund, and an outside attorney who helps with the matters of mortgage and closing documents on such an application. I'm not sure off the top of my head any other issues that increase its transparency, but we can refer to the language in the existing statute and are happy to discuss. We're all for transparency. And I believe our providers who use this application process would love for it to be transparent as well. We're happy to sit and discuss that further. I don't have that at my fingertips today.
Thank you so much, Commissioner. And I just want to make sure if any one of your team members has anything to add, these are pretty straightforward legislative requests. Seeing none. Representative McCarthy.
Thank you, Mr. Chair, and thank you, Commissioner. It's nice to see you again. Second meeting we're in together today. Just to touch base, and if you can remind all of us, the funding for this revolving loan program, is this state funding through the general fund? And has it been, or has there been other funding available through other grant sources for this?
I'm going to ask Nick Gerard, my CFO, if he has any more insight into that. It is, to be clear, though, it's not Medicaid matched funds. It's outside of our Medicaid spend and our Medicaid billing. I will share that there have been agencies that have assisted with securing loans. Some of our providers have other ways of securing loans outside of the revolving loan fund, in addition to some of the state housing programs like HUD and other things. But Nick, if you have more knowledge in terms of the internal workings of the revolving loan fund and how that works, I would appreciate your support here.
Yeah, the funds. So there was seed funding many decades ago.
Nick, can you just introduce yourself for the record?
Sorry, Nicholas Gerard, DDS CFO. So many decades ago, we received seed funding. And at this point in time, all of the funding that we pay out for the loans is actually self-sustaining funding from the revenue of the loans. We charge a standardized interest rate for the mortgage and repair loans. And then over many decades, we've recollected in that funding, had mortgages paid off, and then we're pushing back out that funding for new loans. So the goal of the fund is to be its own self-sustaining fund that takes the revenue it earns from giving loans to these providers and then reuses that revenue to give out more loans to more providers.
That's a great program. That's really wonderful. So obviously you haven't had issues for decades in terms of that sustainability. And I guess my second follow-up question would be, do you foresee that these changes, which makes sense, logical, given the cost of construction and the changes in the economic and fiscal environment, do you see that will have any impact on that sustainability and self-sufficiency?
We don't at this time. We have a good volume of funds from the revenue that we've made throughout the history of the account. And at this point in time, we're actually finding that it's too restrictive. So some of the changes we're making is because obviously DDS needs to help providers acquire homes so that they can provide various services. And it's important for us to be able to give them more flexibility. The housing market rapidly changes. We had some static values in this policy in the past, and with these updates, we'll be able to actually support more providers. So any issues with sustainability are far outside of our worry at this point in time. We have plenty of money to make plenty of loans over the next several years.
Okay, that's great to hear. And final question from me. This is not just for construction, but also for acquiring and renovation as well.
Correct. So combination, so regular acquisitions, like you purchase a home that's already ready to provide services, purchase and renovation. You purchase a home and you need to renovate that home to get it up to the standard so that it can be a licensed group home. It can also be repairs. So you already have a home, there's some repair that you need to make on the home. We'll approve repairs, especially because some of the repairs, large scale roofs, large scale driveways, changes to accessibility in the home can be quite expensive. And so this program allows these providers to acquire that funding. Nonprofit providers in general sometimes struggle to get funding from regular sources because their finances look different than a regular business entity. And so this program gives them that ability to get loans for all sorts of things they need for their licensed group homes.
And I would only add, we don't use this for small projects. When a provider needs to buy and use a contractor to paint interiors, it typically doesn't reach the threshold where they'd be accessing this type of thing. When they need to repair a few steps on a porch or an internal stairwell, their room and board rates with DSS are enough typically to cover that. But when you get to a roof replacement, a driveway replacement, sometimes issues with septic or with furnaces and HVAC, those numbers don't fit well within the room and board rates, and it would mean if providers had to rely strictly on that, they would have to defer other maintenance and other projects. And without going out to the commercial market, this allows DSS and DDS to work with the providers to develop loans for those types of repairs. And we include in some language things about emergency repairs, because we don't want to go through a prolonged process if you need a furnace in February. Our typical process would require all sorts of other activity in terms of multiple bids and pictures and inspections. But if you don't have heat, you don't have heat, and DSS and DDS are able to work with our providers to do things a little more quickly on that. But this is for larger scale, plan for enrichment to existing homes and issues specific to accessibility, or reconfiguring, moving out of one home that's a multi-level and into a ranch. Sometimes we're able to bridge that transition. So they've been used for a variety of things. I've been in the state over 22 years. As a private provider, we did things using the revolving loan fund from just $15,000 on upwards of $100,000 to move out of a lease and into a purchase. So it's a great program. It doesn't answer all of our needs, but it's nice that it can be self-administered.
Thank you. Those answers were extremely illuminating, and I appreciate it. It sounds like this is not just a nice to have, but a necessity at this point. Data Haven, you may have seen, just released information that Connecticut has the active listing rate has dropped to the lowest of any state. So active listings per 10,000 households. So that makes it a lot harder to acquire if we're needing to provide services for people. So I appreciate this conversation. Thank you so much, Mr. Chair.
Thank you. Commissioner, thank you for the work you do and your entire team does. It's very important work and difficult work. I know I have many constituents and I keep reaching out to you to help, and I appreciate you and your entire team coming in to help. And then I know all of our legislators that are here, we have individuals in our communities who benefit from the work you're doing. So outside of this testimony, we'll probably have a conversation to see what the needs may be in future, and perhaps there's opportunity to expand this program, but that's outside the scope of our testimonies too.
Thank you. And if I can just steal 30 seconds of your time, I got to say so at appropriations. I want to say it here. Today, while we are working on doing the good work of the state remotely, I have thousands of staff internally and close to 30,000 in the private sector who had to report to work last night, this morning, and will report to work for second shift at 2 o'clock. We value them. They are essential. And we couldn't do the good work we do without them. So anywhere I can give them a shout out today under ridiculous circumstances for doing their job, I just wanted to make sure I did so. Thank you for the latitude, Senator.
Thank you. With that, we'll move to the next person on the list, which is Deborah Sims. Ms. Sims, you're on. Welcome. I know you're here. There you are. Welcome.
Welcome. So good morning, Senator, representatives, and members of the committee. Thank you for the opportunity to speak with you today and for the work you do on behalf of the people of Connecticut. I am here representing House Raise Bill 5241. My name is Debbie Sims, and I come before you today representing the Easton NRZ and the Mount Growmore team, formerly known as Mount Trashmore. We are organizations rooted in Bridgeport neighborhoods where families are fighting every day just to live healthy lives. I want to speak to you not just about a bill, but about real people who have real lives. In our neighborhoods, children growing up next to abandoned buildings and contaminated lots, families live with asthma and stress and sickness that didn't just start in the doctor's office. It started in the environment around them. Too many of our residents wake up every day surrounded by pollution, poverty, and neglect, and then wonder why they end up sick. We are asking you to see what we see. Vacant land that could become healthy space, children who deserve clean air, families who deserve hope. Triple bottom line justice is about connecting the dots between environment, health, and opportunity, because in our community, those dots have always been connected. Right now, when someone gets sick, the system treats the illness, but it rarely treats the cause. This pilot program would help Connecticut finally address the root problems, not just the symptoms. Through the brownfields to health fields approach, we can turn poisoned land into places where families can grow food, children can learn, and neighborhoods can heal. Land that once represented neglect can become land that represents possibilities. We have already started doing this work, turning neglected land into spaces that bring life back to our community. We have seen what happens when a vacant lot becomes a garden. Neighbors come outside, children learn where food comes from, families begin to feel pride again, hope starts to grow in places where nothing used to grow, but we cannot do it alone. This pilot program gives the state a chance to invest in solutions that come from the community, not just policies. It also helps doctors recognize something that we already know, that where you live affects whether or not you live. By using health data that captures environmental stress, Connecticut can bring more resources into the communities that need them the most. This is about fairness. This is about dignity, and is about whether children growing up in our neighborhoods have the same chance to be healthy as children growing up anywhere else. We are not asking for charity. We are asking for partnership. This is a chance for Connecticut to lead and to prove that when we invest in communities, communities like ours get stronger. Please support this bill. Our neighborhoods are ready. Thank you.
Thank you for your testimony. Very powerful words and important words. And I think if you don't mind repeating the beautiful way you said it, where you live determines how long you live, right?
And my husband died this year, right? A couple of weeks ago. And that has been more profound to me than ever, because if I had known better, and if I didn't do the type of work that I do now, he would have lived longer because I didn't ask the right questions.
Okay. I'm just gonna ask because one of our admins has reached out. Dave, did you raise your hand by mistake, or there's some technical issue going on?
No, it was an error. Sorry.
Okay, perfect. Representative McCarthy-Vahey.
Thank you, Mr. Chair. And Ms. Sims, thank you so much for your work, and I'm so sorry to hear about the loss of your husband. That is absolutely heartbreaking to hear. And I'm sure that it is hard to face on many levels, and appreciate what all of you and have been doing on the East Side, and your leadership in particular on this issue, along with Representative Baker. I wondered if you could just talk about some of the work that's been happening already, how you have been partnering with the community and working with the folks at Yale. I know later we have Susie Rule is also here to testify, but if you could just share with us a little bit about what that work has been like, and then talk about what this bill might be able to do to help the work and to strengthen it and make it better.
So we started our work probably about 3 years ago. Everybody knows about the famous Mount Trashmore site. So we had this vision that we were going to take that site and turn it into a wellness center, a wellness campus, and a hydroponic farm. So every time I think about it, it is probably one of the most impossible sites to do, right? We've been working on it for the last 3 years. We've been meeting every 2 weeks with Yale, EPA, DEEP, the city, the state, just trying to figure out how to get it right. I'm happy to say that 3 years later, we are almost there. The site is almost clean and ready for us to develop. It's in the smack middle of a neighborhood. So our 3-acre site that's located on Central Avenue is clean and ready to develop, but the site around us is not. We know that there are 1, 2, maybe 3, 4 contaminated sites that are around us. So while we're developing a site that is now safe and clean, that our children and families will be able to play and grow on, around us, it is not. So we still have a lot more work to do. We know that in our neighborhood and surrounding, like 1 block over, that we have some of the highest asthma rates that are in the country, but we are not asking the questions, right? We know that what goes on across the street affects the quality of air. It affects whether our families are sick, but we are not asking those questions. We are not tracking that data. We do not know what's going on. I'm going to say that I was not a proponent of that in the beginning because our neighborhoods are often data to death. Everybody comes to the East End and they want to data our people to death, and oftentimes we don't see the results of that data. But in order to understand and try to figure out and try to heal our community, we got to find out what's going on. Everybody in our community is on asthma pump, including me, right? I live down the street from a junkyard. I'm on asthma pump too. But we got to find out and we got to have better guidance when we allow these companies to come into our neighborhoods. They're not in other neighborhoods, they open one up down the street and, oh, it's okay, it's already zoned for that. But we got to holistically start looking at things that really impact the quality of life. We have done a lot of good things over there. So we've started with our community gardens. We're ready for this, the hydroponic farm and the wellness campus. Hopefully this year we'll be able to go into the ground and build that. We produced a lot of paper. We have a real informed NRZ now. They questioning developers. We don't allow certain things in our neighborhood now because we know it's not good quality of life issues for us, but we still have a long way to go, right? We got to get the medical folks at the table, right? You got to listen to people like us. We know our neighborhoods, right? We know our communities. We know what makes us sick. We got to get them to be better partners with us in our community. And I think by having this law, it'll begin to open up the conversation and put folks at the table. That's what our intent is behind that. We gotta, and I don't want to say force, but we gotta get them to sit at the table and talk to us.
Well, you're saying convening people, bringing people together and allowing for the conversation to happen, to understand it in a more
Correct.
holistic way.
Correct.
I also will say you do have some pretty good lines, not that they're lines today, but what you said, sometimes we're dated to death. That really
Right.
struck me. And I think that's one of the questions about this task force is it's really intriguing and interesting to me to look at the understanding of you have a medical diagnosis, and I think we've seen this week, there's some data coming out about asthma, air quality, not asthma, air quality and dementia, Alzheimer's, actually. So you're looking at those medical diagnosis, but also the environmental piece and the insurance piece. And one of the challenges that I'll name, and Rep. Baker and I have talked about this, is that in public health, we're the public health committee, we're not the insurance committee, we're not the environment committee. So we are going to need to talk with our other committees too, to help them, because this is a bill that brings all those pieces together, which is what you're saying. What I'm hearing you say is that by bringing the pieces together, we would then be recognizing what you are experiencing, which is this is what's happening where we live. And the last follow-up question I will have to that, with this task force or with this bill, what in the end what are the 1 or 2 or 3 primary goals or things that you would hope to see as a result of this? So it's not just data to death, but then what happens? What are, kind of very specifically, as much as you can?
So I'm hoping that it's early intervention, right? So when you talk about dementia, that is all over in our neighborhoods, right? That is huge in our community, with folks taking care of family members that have dementia. And if we could have caught that earlier, if we were aware of the signs earlier, maybe somehow we could have prevented it. I'm not saying stopped it, but slowed it down. So I'm hoping that prevention is a big thing. Maybe we can control the amount of children and families who are impacted by asthma. We have a lot of these families wearing these heavy asthma. I don't even know what it's called, but some kind of vest because their asthma and stuff is so bad. So prevention is the big key for me in controlling it, the diseases that come out of these communities that we all live in. I happen to live in a community of which I serve. So it is really, really concerning for me. And we just got to change the way that we do business. And Connecticut could be a leader in that. I am sure of that.
Thank you so much for the work that you're doing and for being with us here today. I really appreciate it.
Thank you for allowing me to speak today. I appreciate that.
Representative McCarthy Vahey, Representative Mara.
Yes, thank you, Mr. Chair, and thank you for speaking up today on this topic. This is very interesting. I'm just as I'm kind of going through the bill and understanding, where we are. It looks like this is more of a focus on making sure the brownfields are converted and linking those. And I'm trying to figure, are the brownfields already those particular brownfields, are they already linked towards asthma, or is this going to have a study to see? I'm sorry, I don't know which community you're in, but I don't know if there's other factors that are in your community too. When we look at public health, I kind of like to make sure that we include everything. Like if you're in a high traffic area, are we talking about traffic pollution as well? Are there other environmental concerns? I just want to make sure if our end goal is reduction of asthma, that we're actually looking at everything that's involved around asthma. So maybe you can help me out with a little bit of that.
Sure. So we're looking at everything. We are in, high traffic areas. It's a holistic approach. It's not just, it is brownfields, but it's everything surrounding that as well too.
Okay, but this particular bill is just focused on the brownfields.
Yes, brownfields. So brownfields, but when I talk about the brownfields, so we got to talk about the trucks that bring the stuff to the brownfields, right? So I can tell you right now, across where I'm talking about, where our Mount Gromore site is, every day across the street, the brownfield site across the street has about 100 trucks that deliver construction debris to it. So we got to look at that too, because that's also part of the problem to the next brownfield site.
Okay, so there's more than just, because some of the brownfields are just old plots of land that aren't used anymore that are sitting there unused. You're
Correct.
talking about a very active dump site. Is that-
Correct.
Okay. All right. Okay. Thank you. I appreciate that.
Thank you.
Thank you so much for your testimony. I've been looking at the pictures of Mount Trashmore and Mount Gromore. I love it.
Thank you. Thank you. Please visit us whenever you're in Bridgeport.
Love to. Thank you. With that, seeing no other questions, we move on to the next person on our list, Mr. Lou Rinaldi. Mr. Rinaldi, you're on.
Good afternoon, members of the Public Health Committee. My name is Lou Rinaldi. As the originator of Connecticut Public Act number 2379, section 49, which established the nation's first office of the Cannabis Ombudsman. I speak to you today rooted in a deep commitment to patient advocacy and rational, evidence-based health policy. I'm here to offer conditional support for Raise Bill 5242. This legislation promises compassionate end-of-life care by allowing terminally ill patients to access medical cannabis within healthcare and hospice facilities. However, to turn this promise into a reality, we must directly address the opposition from the Connecticut Hospital Association and the Connecticut Association of Healthcare Facilities, while simultaneously fixing burdensome patient restrictions within the bill's current language. I see we've got almost all the co-sponsors on this call right now, and I'd like to thank you for your work on this bill before I proceed. To our colleagues at the CHA and the CAHCF, I validate your concern. Protecting your DEA registrations and CMS funding is paramount to keeping your doors open. However, opposition based on federal illegality ignores the ironclad structural safeguards already present in this bill. The no-touch chain of custody, for example, this bill does not force your pharmacists or nurses to procure, dispense, or handle a Schedule I substance. The language clearly places the responsibility of storage and use on the qualifying patient. By shifting the administration entirely to the patient, your clinical staff and your DEA registrations remain insulated. There's also a built-in exit ramp. If you fear a sudden shift in federal enforcement, I direct your attention to Section 1D, that's 1 Delta. This provision explicitly allows a facility to suspend compliance if a federal agency issues a rule or notification prohibiting cannabis use. You are not permanently trapped by a state mandate. The bill legally protects your right to suspend the program instantly if your federal funding is ever genuinely threatened. The reality of precedent should also be considered. In states like California, which passed similar legislation known as Ryan's Law, hospitals of all sizes comply without issue. To date, CMS has never revoked a hospital's funding, nor has the DEA revoked a facility's registration for allowing a terminally ill patient to self-administer state legal medical cannabis. While we must protect our facilities, we cannot do so at the expense of the patients this bill is meant to serve. As currently drafted, several restrictions undermine compassionate care. I'll start with the blanket ban on inhalation. Section 1 explicitly prohibits both smoking and vaping. Banning all inhalation removes the fastest and most effective route of administration for patients suffering from breakthrough pain, respiratory distress, and severe nausea. While combustion is entirely inappropriate in a clinical setting, dry herb vaporization must be explicitly permitted. Unlike liquid vapes or traditional smoking, dry herb vaporizers gently heat raw cannabis flower below the point of combustion. This provides rapid symptom relief without producing smoke, ash, or tar, making it safe and suitable for a controlled healthcare environment.
Mr. Rinaldi?
Yes.
And I should let everyone know, I get to be the voice today because Kathleen is having technical issues. So that's your 3 minutes. If you can summarize, that would be great.
Sure. There's also some restrictions on lockboxes that are somewhat subjective, and there's an emergency care ambiguity. I'm happy to talk about those offline. In conclusion, we have an opportunity here to lead the nation in compassionate end-of-life care, vastly improving palliative outcomes and honoring patient dignity in their final days. I urge the committee to amend this bill to explicitly permit dry herb vaporization, remove the locked container mandate, and clarify the transition from emergency care. To the CHA and the CAHCF, I urge you to look closely at the fail-safes provided in this text and stand with us in supporting these suffering patients. Thank you for your time, and I'm happy to take any questions now.
Thank you for your testimony. I will have Representative Claridis Dietra. She actually is one of the champions of the bill to start the conversation, and we'll have more opportunity.
Of course.
Thank you,
Hello,
Mr.
Representative.
Hello, Mr. Rinaldi. Thank you so much for being here. And I want to thank you for coming in and explaining, a lot of this to people so they have a better understanding. A couple of my questions are, besides California, what other states have passed this Ryan's Law?
So Ryan's Law is unique to California. I would have to do some additional research into other implementations in conjunction with our cannabis ombudsman, who I believe is in attendance of this hearing right now. But I can certainly follow up with you offline on that.
Okay, thank you. And then the follow up to that, you talked about the issue with storage. What's the recommendation of how each individual patient would store and, have their medical cannabis on their person?
So, as you know, the bill allows facilities to reasonably restrict storage, including requiring a locked container. So, in a lot of these cases, these patients who are terminally ill are not necessarily able to manipulate locking mechanisms depending on the type of lock. There are, keys and combination codes that can be agonizing and an unnecessary physical hurdle for the patient. And also, if we're not clearly defining what reasonably restrict means, a hostile facility could implement consumption rules that were so narrow that they effectively block access altogether. So I guess it's a little bit more granularity in terms of how we are attempting to prevent these items from getting into the wrong hands, although within a facility such as that, I wonder about the true risk. But we also need to take in mind the physical disabilities that may be impacting some of these patients. And if I may, I did just get a note from our cannabis ombudsman who says that there are 13 other states who have enacted laws similar to Ryan's Law. And she asks that you refer to her written testimony. That's Erin Gorman Kirk in the Connecticut office of the Cannabis Ombudsman. She's pointing out that there are 13 other jurisdictions in which this has already been enacted.
And you said Erin Gorman?
Erin Gorman Kirk, yes.
Okay. And then, that reminded me of something else. Oh, and CHA, and their concern, and rightfully so, is losing federal funding.
Yes.
If you could get us, so obviously none of these other 13 states have had an issue with their federal funding being revoked. So I think that's important for people to know that and I understand, and they should be concerned, and they want to make sure that everything is written in such a way
Absolutely.
that they're not going to, risk losing any of their funding, because hospitals need it. They need every penny they can get.
That's correct.
Well, thank you again for being here. Any information that you have, would be great to send it over to us.
Absolutely. I'll be following up with you via email. Thank you so much.
Thank you. Thank you, Mr. Chair.
Madam Co-Chair, Representative McCarthy.
Thank you very much, Mr. Chair. And thanks to Rep. Claritas Ditria for her being a champion on this issue. And Mr. Rinaldi, as I get to be the voice today, actually am interested to go back to your testimony. And if you could just very clearly again outline those you have three specific recommendations. One, I heard you were talking at the end of your testimony about the inhalation ban and that's a problem. So to allow for dry herb vapor inhalation. The second is the removal of the locked container mandate for storage because of the problems you just outlined in conversation with Rep. Claritas Ditria. And then the third, if you could remind me of that third.
Sure, yeah. And I'm happy to speak about any and all of those. But the third is the emergency care ambiguity. The bill explicitly forbids cannabis use while a patient is receiving emergency care. And this is really more about the granularity in the statutory definition. Without a strict legal definition of when emergency care ends and stable inpatient care begins, a patient could be stalled in an administrative gray area, unnecessarily delaying their right to their medicine. So I don't necessarily think we need to remove provisions around lockboxes and definitions of emergency care. I think it's just a drafting revision to maybe as Representative Claritas Ditria said, look at some of those other jurisdictions where this has already been implemented successfully, and maybe look at the language that was used in those scenarios to try to solve for those two issues that I highlighted. And regarding the inhalation, that is also correct. Nobody wants to see combustion happening in a clinical environment. I think we all understand that there's a number of problems and concerns with that. The technology behind the dry herb vaporization There's actually a company based in Germany called Storz and Bickel that produces medical cannabis vaporization devices explicitly for use by medical patients, particularly in palliative care scenarios. So there's precedent there, and there's ways that we can look at allowing the inhalation and the immediate onset effect that it brings without having, thick clouds of smoke drifting through a healthcare facility, which we all agree is in nobody's best interest. I hope that answers your question.
Absolutely. That's very helpful. I would also ask that if you're sharing information, if you would kindly send it to Beverly Henry, that way the entire committee will be sure to have access to it, because I think it will be helpful as we move forward in this conversation.
Happy to do so, Representative. Thank you.
Thank you for being here today. Thank you, Mr. Chair.
Thank you, Rep. Mara.
Thank you, Mr. Chair. Okay, so I'm looking through the bill, but I also kind of checked through the Ombudsman report, and this all kind of makes sense to me. The only part that I have a problem with is, and I know this is not in the bill, but is the dry herb vaporization. Well, I realize that there's less odor with something like that. It still does produce an odor, which I think is, I don't know if you have any comments on that. To me, that seems like it's one thing to make sure that someone is having that palliative effect, but if they're doing that at the risk of someone else around them having to now smell cannabis in the hospital setting, that seems like maybe a non-starter, but I don't know if you have any thoughts on that.
That's actually a really astute observation, and I commend you for drawing the distinction there. There is absolutely an odor associated, but it is, I would consider it orders of magnitude reduced from traditional combustion. I also think that we have a number of options in terms of active ventilation systems that can be utilized for this purpose. We see them implemented in healthcare facilities. We see them implemented in even in our casinos and other facilities where air quality is of paramount importance. I think that there is room to investigate, certainly, to look into options for permitting dry herb vaporization while not having it infringe upon the health and or well-being of any other patients or staff in the facility. I think it at the very least warrants an exploratory investigation to determine if this is something that we can make work, because the benefit of allowing this, again, in terms of the different routes of administration that are available, this is something that would have comparatively the fastest onset. When a patient takes an edible, for example, they could be waiting 45 minutes to an hour for relief to set in, and other mechanisms are also similarly time delayed. And it's of great importance that we're able to provide as quick relief as possible. So yes, you're absolutely correct, and I would like to lend my efforts, my time to assist with any sort of exploratory investigation in that regard. Thank you.
Okay, thank you. Thank you so much. I think like my concern, of course, is that if we mandate and say that you're going to have to allow this, and you're also going to have to allow vaporized, that is, I'm okay looking at that kind of in the long term. If there's a facility that happens to have an area that has air quality that could be used for that, but I guess I'd be really concerned with the rising cost of healthcare cost, saying now your healthcare facility has to have another ventilation system. I mean, we probably need to focus on the best thing that we can do for people.
Right. And that's why I say exploring it is certainly valuable, because some facilities may already be equipped accordingly and some may not. I don't necessarily think we have to mandate it in the bill. I'm not anything close to policy counsel, personally, but I think maybe if we can include it as at least an option in a revised draft, to allow facilities on a case-by-case basis to determine if this is something that they are equipped to support or not. And then maybe at a future point in time, they elect that they would like to move in that direction. They certainly have it within the realm of possibility to do so. So, maybe not a strict requirement, but certainly maybe an exception to the blanket ban on inhalation on a case-by-case basis.
Right. Okay. Thank you so much.
Thank you.
Thank you. So I just wanted to ask a couple of questions. And first, I wanted to make a couple of comments. So when a person is in hospice or close to end-of-life care, there's a lot of anxiety. And the families that are around them, we use benzodiazepines quite a bit. And that would make a person very sleepy and take care of the anxiety too. But you may lose some moments with the loved ones when you're knocked out, so to speak. So this option is a very reasonable option where it would create some calmness, but not necessarily have the person be completely sedated. So that's why I'm one of the supporters and co-sponsors of this bill too. So I wanted to give the rationale that why is it worthwhile? Because for some families, it's going to be very relevant. It's an anxiety controlling medicine in that situation and without causing some of the side effects from some of the peer medications, if you will. The second part is the sublingual cannabis oil is available, which has a pretty fast onset of action. And we do not necessarily need to get into the inhaled dry version where the temperature is very high and you have oxygen in most of those patients. So you don't want to add more complexity to a situation where the hospitals are already struggling for other reasons. We should actually look at it. What can we do to take care of the patient's needs? And what can we do to be able to make sure that the people who are hesitant, give them comfort about this? The fact that 13 other states have been able to do this should give us a little bit of a comfort then that it's not as much of a federal issue. The federal laws are not changing. As we know, it takes a long time to change a federal law. They will come together and probably change some of the laws, but they're going to have a lot of inertia because they're dealing with interesting other issues. So therefore, I think it may be worthy to look at the lockbox part and some of the other components a little bit more. And this is just me speaking. Of course, we will all sit down and have conversations, but that's where I think maybe an opportunity. But your testimony is really helpful, and the testimony of many of the others is very helpful to us. Thank you.
And I'm grateful for your work on this bill. I think this is really a step in the right direction for a state that has, we've made cannabis legal, but we haven't necessarily done the work to counter some of the longstanding stigma associated with the plant. So I think this is a fantastic step in that direction in a way that is able to demonstrate, positive outcomes for patients. So thank you.
You had raised your hands earlier, Representative McCarthy-Vahey. You good? Okay, seeing no other questions or comments, thank you for your testimony.
Thank you so much.
Thank you. Next person on our list is number 8, Michael Duenas.
Good afternoon. Thank you to the co-chairs, vice chairs, representatives, ranking members, and members of the Public Health Committee. The Legal Environmental Assistance Foundation, LEAF, is a 501c3 tax-exempt organization that was established in 1979. It provides education and technical assistance to underserved communities facing pollution, environmental injustice, and health risks, very similar to what Deb Sims testified to. LEAF provides public testimony today in support of Health Bill 5241, an act establishing a triple bottom line justice demonstration pilot program. As LEAF's chief public health officer, a licensed physician, doctor of optometry, currently practicing in Connecticut and seeing patients from the Bridgeport area, mind you. And I'm a previous health scientist who served the U.S. Centers for Disease Control and Prevention, National Center for Chronic Disease Prevention and Health Promotion. And I'm testifying that as written, this bill would establish a one-year pilot project that would support community public health and mirror LEAF's goals for marginalized communities in several important ways. LEAF and this bill both support innovative models of healthcare access, considering impacts of a polluted and built environment. LEAF and this bill recognize that people most improved access to healthcare are the ones that are the residents living with contamination and have accessibility to brownfield sites. Number three, LEAF co-developed the Brownfields to Healthfield program, a community-driven approach beginning in the late 1990s, and continues to support its use, as in this bill, as a positive multiplier effect on disease prevention and chronic disease management. LEAF and this bill both view IDC-10 Z codes as critically important, but a vastly underutilized and often never addressed component of our healthcare payment system that holds unique, untapped value in documentation of social, economic, and environmental issues related to health. These Z codes have many advantages over other data sets, as they are codified and tracked by CMS, Department of Health and Human Services. They're accessible to healthcare scientists, and they're payable to providers when they're coded to the highest specificity levels. LEAF and this bill address health issues in communities the size of Bridgeport, where LEAF has been working and assessing community health issues over the past 3 years. Two of those issues that LEAF has been working with is access to comprehensive vision care and mental health care services for children, and early diabetes prevention care for adults through the Mount Gromore B2H project. I'd like to note that these efforts supporting Bridgeport will be given in a written testimony that we will provide the committee. But in conclusion, this bill introduced by your Public Health Committee represents a deep understanding of the authorities to influence positive change. The institutionalization of new data sources, and right now those data sources are only used by physicians 1.4% of the time, and healthcare access can rearrange state and the nation's healthcare through
You can
TBLJ.
summarize, your 3 minutes are up. If you can summarize that.
I sure can. Thank you, Representative. LEAF looks forward to your support for H-Bill 5241 and hearing its reputation of this committee. I know that you'll be able to positively influence actions and developments in improving healthcare access by solidifying TBLJ principles through this bill. Thank you.
Thank you so much for your testimony. Seeing no questions, we'll move to the next person on the list. Thank you.
Thank you.
Next person on our list is Greg Allard. Thank you so much, Greg. We're going to keep you busy this session.
Oh yeah, it seems like it, and I'm happy to be testifying at noontime versus 9 p.m. like we did last time. But I'm sure you are as well. So my name is Greg Allard. I'm president of the Connecticut Ambulance Association, and I'm here regarding Senate Bill 238, an act concerning EMS response time transparency. First, we appreciate the intent behind this bill. Transparency, accountability, and data-driven decision-making are values EMS organizations share. We already collect and report significant amounts of response data to the state. In fact, much of the data contemplated in this proposal is already transmitted electronically in real time after each call. The data meets national NEMSIS standards and is used by the Office of EMS in Connecticut in its annual report. So from a technical standpoint, the data exists. The key issue is context. So under Connecticut's EMS framework, each municipality is supposed to establish its own local EMS plan, including written agreements and response time benchmarks. However, each response standards are not uniform across the state. They vary based on geography, call volume, staffing models, and local contracts. In some towns, multiple providers operate under different standards within the same municipality. At the same time, compliance with municipal EMS planning requirements is inconsistent. Only about 46% of the municipalities currently have an up-to-date EMS plan on file. Nearly a third have expired plans, and some have never submitted one at all. That lack of uniformity matters. If a statewide dashboard publishes average response times without reflecting each town's adopted standards, it risks creating misleading comparisons. An organization fully meeting its contractual obligations could appear to be underperforming simply because it's being measured against a different community's benchmark. There are also operational distinctions that must be addressed. Will the dashboard differentiate between hot and cold responses, which is lights and sirens or no lights and sirens? They carry different urgency levels and response expectations. Will it distinguish between different service levels that may be provided by separate agencies under separate contracts? Aggregating all of that into a single average could obscure important differences and create confusion. We support transparency. We also support using response data to strengthen federal grant applications and target resources to communities that need improvement. If developed carefully in collaboration with EMS stakeholders and municipal leaders, this initiative could improve system performance. We respectfully ask that the committee ensures that any public dashboard reflects locally adopted response standards, distinguishes between call types and service levels, and is paired with stronger compliance requirements for municipal EMS planning. Thank you for consideration and continued support of Connecticut's EMS system. Thank you.
Thank you, Greg, for your testimony. Greg, I wanted to brainstorm a little bit with you.
Sure.
There are parts of our state, and we've had this conversation, there are EMS deserts. Where for a variety of reasons, we do not have enough paramedic staff or EMTs, and we have one ambulance for a community that is a large town geographically, but a smaller population. And the response time and the mutual aid sort of causes a delay in providing that service. We are thankful that we are going to be recipients of the Rural Health Grant. And rather than just putting money into it without a strategy, we need transparency around the timeline of this response. I've looked at the dashboard for New Jersey, and they have it actually not on a daily basis, but they have it on a monthly basis to be able to see the patterns, so that if as a state, we actually start to use this data to be able to make policy adjustments. Again, the whole idea is we can have preventive policy or a reactive policy.
Mm-hmm.
We are already small disasters, but we don't want to see a major one before we actually say, hey, let's go back in time and fix that. This is the time to address the areas of weakness in our state, the response times that are weak in our state, and then try to invest, because we will have the resources to invest. And we are already working on the EMS compact that you actually testified on.
Yep.
So all those things are in place. We have an opportunity to invest in a strategic manner so that our money goes farther. That's a rationale. And can we find that strategy to be able to address this?
So yeah, I think there's opportunity there for sure. And I think putting all of these pieces together, like you're mentioning, the compact and working on other ideas for workforce enhancement. As you know, EMS is struggling with the workforce. Part of that has to do with reimbursement as well. Interest in EMS is also waning. The pandemic was a big part of that. Turned a lot of people away from that, from EMS, just like it did with healthcare in the hospitals. So I think there's not any one particular solution, but I think it's definitely something that could be worked on in conjunction with all those pieces to make it certainly a better system overall.
Thank you. And I have more questions, but I have my co-chair ask the question. I'll come back.
Okay.
Thank you, Mr. Chair. And Greg, it's nice to see you. Thank you for your partnership with us. And there's a lot more conversation to be had about this one for sure. I know we'll be continuing the conversation offline and also with the other EMS compact bill. But one of the things that you said, you were talking about the differences between municipalities and the fact that the standards could be different for different providers, even within one municipality.
Yeah.
In other words, the question is it solely contract dependent?
No, really what it's supposed to be based on is the EMS plan for each municipality. And in the case of some of the larger municipalities, they have multiple providers. And however the municipality works with those providers when setting up those agreements, that's what that municipality decided was acceptable within their municipality, within their community. It's unusual, but I think it does exist. But really, the municipality should sit down with the provider to make that determination what those response time our benchmarks are acceptable, or just to talk about EMS in general. And like I said, there's very few municipalities, 46%. So less than half of the municipalities in the state have those plans in place. And there's a number of them that have never even established a plan or started that communication. So, but there's nothing in statute that says or gives any teeth to the department to give them any strength to make sure that they do comply with those plans. So I hope that answers.
Nothing, it does. And let me follow up. There's nothing in statute that is requiring municipalities to comply, or
there's language there that says they should, but they don't, obviously, because of the numbers that we're seeing as far as compliance. But there's nothing that really says that the department has the strength to go back and enforce them to do that.
Okay, so I'm still a little not understanding then. So if there's one EMS plan for one particular, we'll just say City A, won't name any names, and City A has a plan and there are multiple providers, what would lead them to have different response time metrics for different providers?
I honestly don't know what that would be. You would think that they would expect to have the same standards for each provider. Sometimes it's different based on the level of service that's being provided. If they have a basic level provider that's housed within the town, and then they're getting ALS providers, or the paramedics are coming from another community, that time difference might be a little bit different. But within the same community, having two separate organizations that are providing both the same levels of care, you wouldn't expect there to be a difference. But I'm aware of one community that has that.
Okay, thank you for this conversation, and I look forward to more discussion going forward. Thank you, Mr. Chair.
Thank you. So Greg, I saw the testimony from our commissioner from Department of Public Health, and they're saying that we do put in the information once a year, and it's not that easy to find. It's not in the form of a dashboard, but it is there, and you probably may have to do some searches to get to it. But I know that other states are doing it much more frequently, and I think the part that I think once a month would give us a little bit more insight than once a year. And then right now, the report that we have is about, we're in February now, so it's from 2024. So I don't know when the 2025 report will come out. But you're saying that you're providing information to the state on a regular basis. How frequently is it going to them?
Well, we kind of call it real time. So when a call is completed and goes into our database, it's submitted, from what I understand, monthly to the department for them to have access to be able to report on and develop reports or whatnot. So I would think that your dashboard requirement could be met.
Okay. And right now the bill doesn't say it, but if we were to find a common ground and say, okay, let's do a monthly update, that would be helpful.
Yeah, I don't disagree.
Okay, and one of the things that's not in this bill is one of our colleagues had put in a legislative request, which was that if a person needed a transportation, is there a way or a mechanism to be able to get a real-time information of how long would the wait be if the person is going to be transferred for a non-urgent versus urgent issue?
And by that, I'm understanding from a hospital to another facility, or from something along those lines. Is that really important?
So from a house to a hospital and from a house to a facility. So sometimes what happens is if you're going from a hospital to a rehab facility, you can wait for 4 or 5 hours, and that what happen is that you lose that day, and then the facility says we cannot accept you.
It depends on the systems and the services that are providing the service, at what they have available to them and what could be created from that. So it's very system or very, software dependent as to whether you could build that dashboard.
Okay. So in other words, right now we are not able to give much powerful timeline of this.
Yeah, so the response time piece from like wherever we're responding to somebody's home, that would be rather difficult because that ambulance could be at any particular point in time wherever. So that would be a difficult one to do. The one where we're leaving or going to the hospital to give an anticipated pickup time might be something that'd be a little bit easier because they're non-emergent in nature. But some of the hospital systems have systems that are able to monitor and look at that type of stuff. But again, it's going to be system dependent on the EMS service as to whether or not they're going to be able to provide that data.
And can I look? Technology is advancing quite a bit.
Yep.
And to give you an example of Lyft and Uber, they track every car when it is on service to know exactly where they are, what's the timeline, they're going to be at such and such time in such and such place. And this is just regular travel, non-emergent travel. In most cases, you're going to an airport or wherever. And I think the technology exists with the ambulance, but it's disjointed. And there is no cerebral part and the central part to look at what's going on where. And on a good day, we don't know what's happening. If God forbid there's not a good day, how are we going to improve things? And that actually just bothers me every time because we are not using technology the way we need to. And we are going to have hurdles even to get a dashboard for once a month. And people are moving towards every second information.
Yeah, I mean, some services don't track their vehicles. There are plenty that do, but there are a number that do not, and for whatever reason that is, whether it's cost or technology or they don't feel as though there's a need, but there are quite a few of us that do track our vehicles and know where they are, providing directions and that kind of thing.
I think this bill doesn't address this, but perhaps there's an opportunity to have a conversation to bring us to technological advances so that we can identify areas of opportunity. It's not supposed to be punitive. It's supposed to be more to find out how can we do better in some of these areas so that because every second is critical in an emergency. And we'd hate that our systems are not ready for those emergencies. And that's the part that we can fix and do better at.
Yeah, and I think again, as long as that dashboard has, or whoever's going to be tracking that information has the ability to take information sources from different softwares to be able to build that together, that would certainly be helpful because, one tracking system is just that, it's one tracking system. It needs to be able to be read by a dashboard would need to be manipulated.
And that's why I feel it should be top down rather than bottom up, because then we'll be dealing with 169 different systems. So we have a top-down strategy. So there's a central place that collaborates and works with everyone. And this is something that would be necessary in future. But if we don't do it now, you're the first responders on a good day, and God forbid not on a good day.
Mm-hmm.
And on a good day, we are not able to have a better handle of the broader picture. And if there is not a good day, how are we going to be better prepared? And that's where investments right now would be relevant.
I agree.
Thank you for your testimony, and thank
you're
you every day. Thank you.
You're welcome. Thank you.
That brings us to the next person on our list, which is Elizabeth Caldwell. Ms. Caldwell, you're on. Thank you for your patience with us. Welcome.
Of course. Thank you, senators, representatives of the committee, for allowing me to offer my testimony in support of Senate Bill 239, an act concerning nutrition and food-based interventions for patients with diabetes and congestive heart failure. This would mandate that community health needs assessments identify and address nutritional needs of patients with diabetes and heart failure. My name is Elizabeth Caldwell, and I live in New Haven, and I'm a graduate student in the Health Policy Department at the Yale School of Public Health. My volunteer work at free clinics, including those in Connecticut, I've been able to sit with patients whose diabetes or heart failure was initially stabilized through medication, only to see their prognosis worsen over time. The common culprit is often inaccessibility to the proper nutrition. When we send patients home with prescriptions but without access to medically appropriate food, we're delivering incomplete care. And ultimately, a clinician's dietary recommendation is completely meaningless if the patient can't actually access that food. There's clear evidence that medically tailored meals are not merely supportive services, but actually clinical interventions. A 2019 peer-reviewed study found that patients receiving medically tailored meals experienced a 49% reduction in inpatient admissions and a 16% reduction in overall healthcare costs compared to matched controls. That is a dramatic impact on both patient outcomes and spending. And more recently, a 2025 study projected substantial reductions in hospitalizations and healthcare expenditures nationwide through the use of medically tailored meals. Importantly, our own state of Connecticut was estimated to have among the highest projected net savings per patient in the country, more than $11,000 annually for those with diabetes and over $9,000 for those with heart failure. Now, while I believe that this bill is a step in the right direction for equitable care for people with chronic health conditions, I do want to briefly address some concerns that others may have about this mandate. I don't believe that this bill would eliminate community input or override clinical judgment. I believe that it simply strengthens the alignment between the identified need and the evidence-based response. Furthermore, flexibility without accountability risks perpetuating geographic inequities. A patient's access to medically appropriate food should not depend on their zip code or what hospital is in their network. When the data shows substantial reductions in hospitalizations and significant cost savings, I believe it is appropriate for the state to prioritize these interventions within an existing federal framework, which is the Community Health Needs Assessments. If we're serious about reducing preventable hospitalizations, advancing health equity, and stewarding taxpayer dollars responsibly, we must treat medically tailored nutrition as a part of a standard chronic disease management protocol, and I believe that this bill would be a good place to start. Thank you for your time and consideration.
Thank you for your testimony. Thank you for the work that you do, and thank you for highlighting the relationship of nutrition and the well-being of patients. And I think these two illnesses are very relevant to readmissions and the long-term health of the individuals. The entire healthcare system save money. You've seen some of the concerns that Connecticut Hospital Association has with this. Would you be able to speak to that, and how can we find a common ground? The issue comes down to is that hospitals believe that they're already doing a lot and they have limited options, and they also have been in a conversation say that, do you realize how much we're being asked to pay in hospital taxes? How are we going to do this? So those are part of the conversations we are having with them. Any thoughts?
I appreciate that there has been some initiative to try to address some of these concerns. My concern about that specifically is that it's not being equally distributed across all hospitals when it's up to their own initiative and saying like, well, we want to assess our own community and see what they specifically need. But I think we've shown time and time again with the data that this is not a specific to one singular hospital community, but rather all across the nation. And so I think it's really a health equity concern if we aren't mandating that all hospitals are looking into this a little bit more thoroughly. I understand that there's like a lot of different needs in the community that could also be addressed. But I think since this one is so clearly showing that this could save money very clearly for these two conditions, like while I believe that it should expand to other conditions that could also be benefiting from nutritional based interventions, these two conditions are very clearly shown to save money specifically for the state of Connecticut, which is why I believe that this would not be a harmful policy to mandate it to be included in community health needs assessments. I also think it's an equity concern if we're allowing hospitals to say like, oh, well, I think I'm doing that sufficiently, so therefore I don't need to look into that further, if that makes sense.
Yeah, thank you for your comments. This is very helpful, and appreciate the work you're doing, and thank you for coming and speaking about this important aspect. Good. Thank you. With that, we'll move to the next person on our list, which is Karen Suarez Robinson. Welcome.
Good afternoon, senators and representatives of the Public Health Committee. My name is Karen Soares Robinson, Director of Religious Education, Trustee of Blessed Sacrament Church of the Diocese of Bridgeport, City of Bridgeport East End NRZ member, and City of Bridgeport resident, property, and business owner. I stand before you to express my strong support of House Bill 5241 for a triple bottom line justice framework, TBLJ, the Mount Gromore demonstration and the Mount Gromore demonstration project. This legislation represents an unprecedented approach to foster collaboration between environmental sustainability and public health, an integration that could lead to transformative benefits for our communities. This bill aims to advance critical research by establishing benchmarks that link environmental factors with public health outcomes, by leveraging Z codes, which address the environmental stressors affecting patient health. We are not only enhancing the capabilities of our healthcare providers, but also uplifting communities. There are benefits for all stakeholders, including healthcare providers, pharmaceutical companies, and patients. For healthcare providers, physicians will benefit from improved data that facilitates more precise treatment plans tailored to the environmental factors, thus enhancing patient care. For instance, practitioners can prescribe necessary devices such as respirators or humidifiers to patients facing certain environmental challenges. Pharmaceutical companies, as we identify specified health issues stemming from environmental conditions, pharmaceutical and medical equipment sales will likely increase, driving innovation and growth and market growth. For patients, the individuals will receive better tailored healthcare solutions that could consider their unique environmental circumstances. So it's a true win-win for all involved. Mount Gromore serves as an excellent initiative. This pilot project does not merely aim to rehabilitate contaminated lands. It is designed to comprehensively address certain surrounding communities' needs. It's designed to comprehensively address the surrounding communities' needs by incorporating the wellness aspects encompassing mental and physical health. Mount Gromore offers a holistic solution that acknowledges the profound ways our environment shapes our lives. In conclusion, the TBLJ framework is a pioneering step towards creating agile policies that connect environmental stewardship with health outcomes. This legislation will empower our communities, enhance healthcare delivery, and foster sustainable economic growth. I urge your support to this vital bill for the betterment of Connecticut and beyond. Thank you for considering this testimony.
Thank you so much for your testimony. I have Representative Kristen McCarthy-Leahy with a question.
Yes.
Thank you, Mr. Co-Chair, and thank you, Ms. Soares Robinson. You had perfect timing. So well done. And I just want to say thank you really for your work on this. And you probably heard or you may have heard some of the earlier testimony. I look forward to talking together with some of the collaborators, but really just wanted to say thank you for your leadership. Thank you, Mr. Chair.
Thank you.
Thank you. Seeing no other questions, thank you for being with us this afternoon.
Thank you.
And the next person on our list is Susie Rowe. Susie Rowe, you're on. Thank you for being here.
Yeah, good afternoon, and thank you so much. My video should be coming on. I'm taking away there we go. Good. I'll talk fast. Well, sorry about that. Basically, my name is Susie Rule, and I'm working in collaboration with the East End NRZ Market and Cafe in the Mount Gromore community. And for identification purposes only, I'm a lawyer and epidemiologist on faculty at the Child Study Center at Yale, as well as the Yale School of Public Health. And I'm here today to express appreciation to this committee for raising the bill, the concept, and I strongly support it because it offers and it represents a dynamic pathway, a transformative pathway to get to that intersection of health, environment, and economic challenges and really create sustainable and resilient communities throughout Connecticut. Because the bill, its essence is to create a demonstration pilot that would foster exploration, convening, collaboration, scaling, and systemization of the promising practices and lessons learned that we've garnered from the Mount Gromore success story. And there's three essential components that I wanted to highlight as to why this is such a transformative opportunity for the state of Connecticut. And it starts with a more thorough understanding of what triple bottom line justice is. And again, this is a concept that's not owned by government. It's not owned by academic. It's been developed by community members in collaboration with government, with the private sector, with the whole range of academic and non-government organizations. And again, it's focusing on that intersection, not environment in one corner, not health in another corner, not economics in a third corner. It's the intersection that the people face every single day. And our solutions have to be responsive to what their needs are. It does employ a very rigorous process, which includes an understanding of the authorities, the rule of law. It's grounded in evidence-based decision-making, and most importantly, it's driven by the impact and the voice of the communities and the people who are living government policies. So I think it's important to understand that basis for why we're calling this the Triple Bottom Line Justice Demonstration Project. The second reason why it's vitally important is, again, as we've talked about, it is employing a nationally recognized process called Brownfields to Health Fields, which again was developed by a multi-stakeholder collaboration, and which Mount Gromore is recognized nationally as a leader in Brownfields to Health Field. And that says a lot, and it's due to Deb Sims and Karen and others who've spoken on the call. But I think a key point that hasn't been highlighted yet is the critically important features of B2H being a multiplier effect for building capacity in a community, which includes the businesses around there, leveraging resources and saving money. And this happens because the still vibrant federal funding for brownfields redevelopment to get sites ready for reuse is that cost saver that can then be accessed by the healthcare system to create health end uses that benefit the direct needs of the community. And I want to give a huge shout out to Connecticut Deep, who's been playing an amazing role in all of the successes we've seen with B2H. The third reason, and we've had a lot of conversation of this, is about the use of the ICD-10 Z codes. And as we know, this is an established system to accurately track diseases and health impacts. It's a way to interface with the financial system, the financial infrastructure. And the Z codes are critical because they get to the conditions of place that adversely affect the health. And what we're trying to do here is really foster a conversation and a common language between the patient and the provider to talk about not just the disease, but what are the factors causing that disease. And again, it's absolutely not limited to asthma. As we've heard, there's diabetes, there's cardiovascular disease. All of these issues are either caused by or exacerbated by pollution, and there needs to be a good conversation on that. Equally important, and on a longer term basis, is the collection of that data, which will help determine trends for better government decision making, whether it's health, environment, insurance, or so on and so forth.
Ms. Rule, your 3 minutes is up. If you can summarize that.
Okay, I will summarize it, and thank you so much. So in conclusion, this demonstration pilot will give an opportunity to maximize return on investment for environmental cleanups to benefit the health and well-being of children and families by systematizing and scaling the success stories that we have at the Mount Gromore site. So thank you very much, and thank you for all your support.
Thank you so much. I was waiting for you today because I wanted to ask you a few questions. Okay. Now, first, this project, the more I learn about it, it's very impressive, quite inspiring. Here's the concern I wanted to raise, and then you probably have the one with the epidemiologic background have the answer. The general mindset is that when we clean the brownfields, we actually make them look beautiful. But the health impact for people working in those areas when they're fixed doesn't go away. It may reduce, but it doesn't go away. So while the title Brownfield to Health is catchy, how real is it? How do we have data to prove it, and how is it different?
That is an excellent question, and that's the distinction between brownfields redevelopment and brownfields to health fields. And brownfields to health was again created in the 90s in Florida when the Environmental Executive Order on Environmental Justice was established. At the same time, brownfields was created. The difference is, yes, when traditional brownfields happens, too often it's for big box developments or for high-end developments, residential or whatever. But the B2H process, the components are brownfields is the bad, the contamination. The health is the end use that's going to help the people that are surrounding that site, but the two represents the engagement of the people who are living there. And the reason why Mount Gromor is such a national model is that we've made a lot of progress over the last 20 years around the country on applying brownfields to health fields. This is the first time in the country over 20 years where you have the community members themselves being the community environmental justice developers. And so the conversation from day one involves the community's voice in diagnosing what are the challenges, what are the contaminants that might have come to that site, paying attention to how are they being remediated, but beyond getting that site cleaned up, that's just part one. It's like, what do you put on that site so that it is responsive to all those stressors? So it's that distinction between brownfields redevelopment and brownfields to health fields.
So I'm slow in understanding. I did not understand the fact that, do we know what the emissions are from there? Is there still, because you're gardening as well in that area. So I want to make sure that.
Right. No, that's a great question, because we're coming in with almost a 30-year history of the application of brownfields remediation. That begins with, the phase 1 assessment where you're doing the diagnosis of what do you think is there. Then you come in with the phase 2 and actually do sampling, and you get a good picture of what's there, with the communities actually adding in a lot of information because they saw the trucks that were going into the site. They saw what was buried. But equally important, and this is why, again, the huge shout out to DEEP as well as EPA, it's the monitoring after the remediation is complete to make sure that there's no continuing exposure. So the brownfields piece is this very strong success that we have out of Mount Gromor. The challenge we have now is how do we design that responsive healthcare? And that's why we need the demonstration project, because we've got a lot of conversations about what the challenges are, but we need to make sure that the healthcare that's being offered is responsive to what the community themselves need. And it's not limited to just a causal relationship between exposure and disease. It's really about reverse engineering wellness for the community and what's healthy and good for multiple generations.
Thank you so much. My co-chair has a question as well. Senator McCarthy.
Thank you very much, Mr. Chair. And thank you, Susie, for being here and for your work. And you are right to give such a shout out, not just to the agencies, but to our local leaders who have just been amazing champions, leaders, conveners, etc. This model makes a lot of sense to me, as I think I've talked about both with Rep. Baker and briefly with you, in terms of looking at the multiple perspectives. We know that, for example, in substance use prevention or misuse prevention, we know from lots of social science research that having that collaborative process, not just law enforcement, not just mental health, not just education, all the voices at the table coming together. So this is very logical. One of this, I think the struggles is bringing those various systems together, as you heard me say, that we have in silos is part of the magic of this and also part of the difficulty. So one of the questions I have is, has anything like this model been done anywhere else in the US? Or is this really, I think what you were saying is that this really would be a leader nationally. Is that correct?
Well, actually, there's two parts to my answer to you. And the first is, yes, we have been doing this throughout the country. In my prior life, I was the Senior Counsel on Environmental Justice at EPA, and we were doing this throughout the South, where it's become standard practice of the brownfields. A consulting firm, we've set up projects in Appalachia. The Yale Child Study Center has a project in Grundy County, Tennessee, where we rehabilitated an old abandoned high school and a railroad trail into a community center that provides the lot of the mental health care benefits for the children and the families, and the Mountain Goat Trail is a diabetes protection. I've done this out in Southern California with, taking former abandoned grocery stores into community centers. So yes, the practice of B2H is very well established, and in my written testimony, I provided a lot of links. For me, what is so exciting about this one, about the Mount Gromore success story, is once again, the other projects have been involving the community from the outset. But in this particular case, it's the leadership of what Deb Sims and Karen Soares and Rep Baker have been doing, of really getting that voice out from the very beginning, and that consistent involvement in monitoring the levels of contamination, making sure they're properly remediated, emphasizing things like gun violence as an important part of the neighborhood stressors. So it's really tapping into a lot more of the whole range of health needs that the community has. And again, coming back to Yale, accessing some really exciting programming at the Child Study Center, such as the Child and Adolescent Psychiatry Program that went in and did a Let's Eat, Let's Heal. So it's this chance to take a good practice and really take it to the next level. In a period where we're losing money for healthcare, it's a way to add more money back into the process.
Thank you. I agree with Senator Anwar that it's more exciting the more we talk about this and the opportunity that's here. One follow-up question, and then I'll leave you be for now, though I know we will be meeting and talking about this. But the ICD-Z codes, really my understanding of that, or the way that I put the framework around that, with the caveat that we're not the insurance committee, and Senator Anwar does sit on that committee, but I do not. But is this really a way to kind of help us address the social determinants, really? That's kind of how I look at it, and I wondered if that was an accurate way to reflect that.
Yeah. In my mind, that's a brilliant question, because that's what we're trying to do. And we're trying to move the conversation and the understanding of the disease, more data to tell you how difficult the challenges are, to doing something about it. And it's turning it in from a passive to an active system. And I will say, I've looked at other testimonies, such as by the Connecticut Hospital Association, and absolutely we want all of the stakeholders to this table to work through the challenges and the hurdles to make it an efficient process. But it really is designed to take that, like Deb was saying, data is death, unless you apply it through something like the B2H process, which is get rid of the contamination and then think about restoring the health of the people as well as the place. So absolutely yes to what you just said.
Thank you for your work on this and for all the good work you've done in other places around the country too. Thank you, Mr. Chair.
Thank you. Seeing no other questions or comments, we'll move to the next person on our list, which is Thayer Barkley. Thayer Barkley, you're on. Welcome.
I don't know why my camera's not showing up. Hold on, can you hear me?
We can hear you.
Okay, I don't know why my face isn't showing up though. I don't have it on video. I'm Thayer Barkley. I am the CEO of Sisters at the Shore. I live in Bridgeport, Connecticut. I'm a business owner and a property owner. Do I need to try to get my camera working? I don't know why it's not.
It's okay. We want to.
Okay, thank you. I am actually in support of Raise Bill number 5241 and Mount Gromore Easton NRZ pilot program. I'm really excited because I believe and I see that the importance of the environment and the triple bottom line justice and the ICD-10Z codes are very important to the community. I am also Schaghticoke First Nation, so I say that to say the environment is very important to the community. Our soil, our water, our air has a lot to do with our health. So when this bill is passed, it's going to help the community with by improving the environment, by improving the water, by improving the soil, so we are able to grow better vegetables. Everyone deserves clean water, everyone deserves clean air, and the soil needs to be healthy in order for us to combat some of the diseases that we're facing. The environmental impact on human physical and mental health, including not limited to air, land, and water pollution. So by having this bill passed and letting Mount Gromore continue to do the great work that they're doing in the community, we will be able to give hope, health, and healing as in addition to educating the community that everything works together. All of the things that they're doing in the community works together to make it a more healthy environment. One of the things that the East End NRZ is doing is educating the people. And I really believe that by passing this bill, it's the beginning of assisting others to learn about they can help the environment by getting involved. Thank you for giving me this time to testify. I'm very nervous, never did it before.
You did a great job and within the time, and you got your message very clearly to each and every one of us. Thank you.
You're welcome.
And it was done so well, we don't have a question. It's clear to us. Thank you. All right, we'll move to the next person on our list, which is Alice Hamble. Welcome. Alice is not here. I don't see Alice. Well, we'll jump to the next person, Paul Terbox. Going once, twice. Okay. Robert Brody. Okay. Next is Tanya De Jesus Espinoza.
Hi, good afternoon.
Good afternoon.
Good morning to the chairs and members of the Public Health Committee. My name is Tania De Jesus Espinosa, and I have been a nurse for over 10 years serving under resource communities, and I am here to provide my testimony in support to the Health Bill 5241. I provide a strong support for this bill, the act establishing a triple bottom line justice demonstration pilot program. As a nurse, I have seen how health is linked to the environment. However, there are challenges that are often addressed as silos. So this project changes that by operationalizing the triple bottom line justice framework, an approach co-developed by community champions at academic institutions like the Yale School of Public Health and Yale Child Study Center that focuses on the integration of rule of law, evidence-based interventions, and most of all, the community engagement. Over the past semester, I was part of a group of working with Representative Baker and the East End community at Bridgeport to ensure this model was not just like a top-down policy, but a community-led initiative supported by the rigors of academia. The focus of the pilot is the Mount Growmore Wellness Campus in Bridgeport. And for decades, this neighbors faced what was called the Mount Trashmore. You've heard about it. And through meaningful engagement, that blight is becoming into a wellness center, starting with a hydroponic farm that is already happening and developing into a more integrative learning and health promotion center. While the community have launched efforts to provide healthy food, this bill allows to focus on the next critical area, which is the development of the wellness of children and families. We can use a data-driven framework like the inclusion of ICD tenancy codes to track how the environmental stressors and the social determinants or social drivers of health, like pollution, extreme heat, they impact health, and we can analyze this so we know what are the health burdens within the community. The beauty of this pilot is that it has a statewide scalability. Right now it's a demonstration project, but this is something that can be used in other parts of Connecticut. And by establishing a brownfields to health fits methodologies, we can create a blueprint that can be replicated across all Connecticut, from urban centers to rural towns, to transform the contaminated sites that we have into permanent health assets. So in conclusion, also engaging local universities, community leaders, we can ensure that our solutions are sustainable, measurable, and just. And I urge the committee to support this bill to move Connecticut from Black to well-being. Thank you so much for your time.
Thank you for your testimony and thank you for your good work. Seeing no, we have Representative McCarthy Behe.
Thank you, Senator Anwar. And I want to just say thank you also. I love how you ended that, the sustainable, measurable, and just. And as you heard in earlier testimony, I have the privilege of representing Fairfield and Bridgeport, and health outcomes and longevity are very different. So the opportunity to address this issue in this way is really wonderful. So thank you for your work.
Thank you.
Thank you. I just also wanted to share with you that Representative Baker is an amazing advocate for this work. So he's got all of his heart in it in our conversations. So
We really appreciate his work and all the work that your guys are doing too.
thank you. Well, stay well. And we have the next person on our list, which is Janran Zhu. Welcome.
Yeah, hello, co-chairs, Anwar, Representative McCarthy Behe, and the distinguished members of the Public Health Committee. My name is Yanran Zhou, and I thank you for the opportunity to voice my support of the raised bill number 5241, an act establishing a triple bottom line justice demonstration pilot program. I speak also as a Master's of Public Health student in the Department of Environmental Health Sciences at the School of Public Health at Yale, where I could receive the education that allowed me to help drafting the model bill along with Tanya and other colleagues. I'm speaking as a New Haven resident, but my views and opinions are strictly my own and do not represent the Yale University or the Yale School of Public Health. In resonance with what previous speakers said, the triple bottom line justice principles measure program successes through social responsibility, environmental stewardship, and economic prosperity. These dimensions also resonate with President Biden's Executive Order 14096, revitalizing our nation's commitment to environmental justice for all in 2023, which integrated environmental justice into federal agency missions. However, the current administration, as we all know, revoked the EO 14096 in 2025, as well as EO 14008, which initiated the Justice 40 initiative, diverting federal investments into climate, housing, and clean energy-related fields. Without these legal frameworks, disparities in communities of color and low-income neighborhoods will be less visible on a system level. And with the state authority to legislate remains intact, I think it's only logical for CTJ to continue strengthening environmental justice laws and pushing forward President Biden's political legacy. This not only prevents waste of administrative resources, like Professor Wu kindly pointed out, but it also brings community leadership to the forefront of TBLG programs. I cannot stress enough how interconnected the environment and our health are, just as Deb and Professor Wu have already pointed out. Connecticut has a decreasing trend in ground level ozone and PM2.5 concentrations, but both forms of pollution still cause nearly 200 annual deaths in CT, and these premature deaths occurred because these pollutions can still travel from other states. So by integrating ICD-10 codes into the TBLG pilot programs, healthcare providers can better understand how environmental pollutions compromise health. These clinical data will then provide strong evidence to further state efforts in promoting EJ, helping prevent harm and regulate pollution. As an environmental health professional in training, I stand again in full support of this bill, and I urge the Connecticut Public Health Committee to do the same. Thank you again so much for your time and for considering the community empowering legislation. I'm also happy to answer any questions you may have.
Thank you so much, Yanran, for your testimony. It was very helpful. Keep up the good work. Seeing no questions or comments, we will not move to the next person because you're the last on the list. So, members of the Public Health Committee, thank you for joining us. And this concludes our public hearing. Go to the other ones now.
Thank you, Senator.
Thank you.